my name is Tahseen Chowdhury. I chaired the BMJ Masterclass on Diabetes and Endocrinology. I think the major messages that came through were individualising diabetes therapy in various patients, so I think that's a really important message that I'd like to convey. The other things that came through in the endocrine sessions were around FRAX for osteoporosis. Think about low sodium, but don't jump in and treat it, and think about Conn syndrome as a cause for hypertension. Worthwhile thinking about these conditions as possible causes for hypertension. Thank you.
So my key message is that we're not very good at managing type 2 diabetes in terms of glycemic control, but what we need to do is we need to individualise patient targets, and we need to individualise therapies, which I believe we can do with the new therapies available to us.
My two key messages to you are that everyone with diabetes should have their foot screened on an annual basis, and that they should be informed of their risk of foot disease. The second key message is anyone who's developed an acute foot lesion, and particularly an infection, this needs to be addressed immediately.
So my key messages are that gene testing has come to the diabetic clinic. It's only relevant to a few, but in those few that you make the right diagnosis of monogenic diabetes, then you may be able to take your patient off of insulin, and in some, you'll not only be able to do that, but you'll be able to reassure them that they're not going to get any complications of diabetes.
So the main message of my presentation is that patients with diabetes and chronic kidney disease have an increased risk of all the complications, not just kidney failure, but also vascular disease, problems with the feet and the eyes. We need to manage their glucose control, but it's more difficult in patients with kidney disease to assess it than in those without.
Human insulin was not designed to be given by injection under the skin, and this is one of the main problems facing our patients, because the profile and where the insulin ends up is not in the right place. With changing insulin structure, we can create more physiological replacement for our patients. And the exciting thing is that there's a whole range of new insulins coming that allow us to create more physiological insulin replacement for our patients, hopefully in the very near future.
The general advice when it comes to prevention of osteoporosis is to do FRAX assessment before ordering a DEXA scan. The general advice for everyone aged 50 and above is to have adequate calcium and vitamin D in their diet, exercise regularly. It doesn't have to be weight-bearing exercise, avoid smoking, avoid excessive alcohol, and yearly measurements of height using a stadiometer.
Hello, we've talked about endocrine hypertension today, and the one take-home message that I want you to remember and take back to your practice is that Conn syndrome is an incredibly common cause of endocrine hypertension. 1 in 10 patients that you see with hypertension will have Conn syndrome. It's treatable and curable and will reduce both the morbidity and mortality of your patients compared to others with the same cause of hypertension.
My message about hyponatremia, which is the most common electrolyte abnormality in hospital medicine, is that you very, very rarely have to do anything urgently. There is time for you to make a considered assessment, examine your patient carefully, assess their volume status, and ask yourself the question, does something need to be done now, or can I think about it for a period of time and come up with a really accurate, robust diagnosis that leads me to do the right thing?